Ready? Okay. All right, I'm starting the timer, and here is your question.
Okay.
Right. If you have read and understood and considering it critical care station, how would you manage this patient?
Okay, the manage the patient according to the ABC approach of the CRISP protocol. Airway assessment, speak in the patient if can speak secure airway, if cannot speak, look for any foreign body or any secretion, and the manage it with the shield lift and jaw thrust and removal of any foreign body and any secretion, and maybe need the patient intubation according to the Glasgow scale, and then breathing assessment by an inspection for symmetrical chest wall movement and counter respiratory rate, and then palpation for the trachea centralized, and then percussion and auscultation, and then circulation assessment by two large bore cannula in the antecubital fossa, and take full blood count, urea and electrolyte and blood group and cross match and EBG, and take investigation like ASR and CRP and the carcinic embryonic antigen and the antibody, and start the patient with 1 liter of the crystalloid as Cabella's dose. If not respond, can be added 1 liter of the crystalloid. If not respond, can be added inotrop. Would monitor the patient with blood pressure, urine output, mental status, and the respiratory rate and pulse rate, and the capillary refill time. My professional diagnosis regard the case scenario, inflammatory bowel disease like ulcerative colitis and the Crohn's disease. Another differential diagnosis could be ischemic colitis and amoebic colitis and the carcinoma of the colon and the diverticular disease and the infectious colitis like Clostridium difficile and Campylobacter jejuni.
Good. Can you tell me why the platelet count is so high in this patient?
Yes, the platelet high due to dehydration and due to secondary to acute inflammation as acute phase rectant lead to increase the platelet count.
Hemoglobin is also low. What kind of anemia do you expect to see in this patient?
Yeah, microcytic hypochromic anemia.
All right. Do you think that patient has acute or chronic type of anemia? And why?
What's mom?
Is it acute or chronic anemia? This low hemoglobin, is it acute
Yeah,
or chronic?
yeah. This is acute type of the anemia.
It's chronic. In acute,
Okay,
it will be normochromic, normocytic. Okay,
Okay,
normochromic,
okay.
normocytic. Okay, can you please tell me how would you interpret these images, both on the left and the right? What do you see? These arrows are pointing at what?
Okay. This is erect abdominal X-ray. I am
Yes.
showing to dilatation of the ascending colon and the transverse colon with the thumbprint sign.
Okay, and when do you see thumbprinting sign?
Thumbprint sign seen at the descending colon and the sigmoid colon.
When? Because of the presence of edema?
Yeah. Yes,
What
because of the
happens?
large bowel wall
Yes.
thickening caused by edema secondary to inflammatory process and the infective causes. A normal hysteration become thickening at the regular interval appear like thumbprint projection into the aerated lumen. The thumbprint sign specific for inflammatory bowel disease and the ischemic colitis and the pseudomembranous colitis and the diverticulitis and the lymphoma of the small bowel and the amyloidosis of the small bowel.
Very good. Okay, since the patient has hemoglobin low, 8.7, would you recommend a transfusion of blood?
No,
Why?
because of the state of the sepsis and not indicated
Yes.
because of the state of the sepsis and not indicated as hemoglobin not below the 7 gram.
Okay, can you tell me please why sodium and potassium both are low?
Because of the patient loss of the fluid from the diarrhea and the dehydration led to hyponatremia and hypokalemia.
Yes, loss of electrolytes as well. Okay, these investigations has been done so far. What other investigation would you ask for in this patient?
What's mom?
What other investigations would you ask for
Yeah,
in this patient?
yeah, yeah. ASR and CRP to assess the severity of the disease, stool analysis and culture to identify the organism of the bacteria and carcinogenic embryonic antigen as a screening for the CO colon and the antibody for the ulcerative and Crohn's disease and colonoscopy can be done at the late stage, not in the acute because of the risk of the perforation.
Where would you manage this patient? Where are you going to
Yeah, diminish
manage?
the patient in the yeah diminish the patient in the ITU
Who would you
because the
involve?
risk of the
Yes,
hypovolemic shock because of the by history in this patient.
yes, yes,
Yeah, yeah, need after MDT meeting with the general surgery and the internal medicine doctor uh, and the histopathology and hematology to detect and identify the cause of the blood area after that
yes.
yeah
Okay. Who would you involve in the management of this
treatment
patient?
general surgery and hematologist and the internal medical
Medicine.
doctor can be managed the
Okay.
conservative treatment and can be managed the surgical treatment according to the situation of the patient and the duration of the patient.
What are the things that you will monitor to monitor the response of the patient?
Yeah, by clinical and laboratory, by clinical fever settle and the diary stop, and the laboratory by the decrease CRP and the decrease the total leukocyte count and the albumin.
Okay, good. Can you tell me what are the indications of doing urgent surgical management in this patient?
Yeah, toxic megacolon, refractory to medical management, fulminant attack, refractory to medical management, perforation and risk of the obstruction and stricture, and the suspicious with the cancer and the uncontrolled colonic bleeding.
What are the surgical options that you will offer this patient? Surgical
Yeah,
management of,
panbroncholectomy with
yes,
the ileostomy.
good. How would you manage the
Panbroncholectomy with ileostomy.
very good. How would you manage the nutrition of this patient?
Yeah, the managed the nutrition of this patient by start with the enteral fitting and the best the total parenteral nutrition
Very good. Okay.
according to the body weight of the patient.
Yes. Right. Good. Thank you. Present. Right.
Thank you, ma'am.
Anything else I could have asked you? Thank you.
Thank you, ma'am.
Yes. Chronic, yes. Anything else could have been asked? Anyone want to give feedback? Yes, you did well. Yes, that's good.
I want to ask.
How are you? Yes.
I'm fine. So, from when you asked him how he should manage the patient, they have already given you the lab, but he was repeating them again. Is that right? After giving you all the parameters.
I couldn't hear your whole question. I'm sorry. Voice
So,
disappeared.
sorry. So when you asked him to manage the case, so he repeated all the investigations that were done, and then the values were already there. So he repeated them again. So in case of exams, they've already given us all that.
Yeah.
Should we repeat it again? That's already
No. No. Then there's no point repeating everything again.
yeah. Okay.
Yeah.
Because he repeated it, so I thought maybe.
No. Everything was given, so don't have to repeat everything which is already said. It will take
Okay.
more time of your time.
Oh.
So in
Okay.
that you can maybe answer some questions.
Okay. Okay.
Okay, Dr. Ulfat, would you go next, or
Yes, ma'am.
would you be
Yes,
able
ma'am.
to go next? Or Dr.
Inshallah,
Salim,
ma'am.
he has joined now.
No, ma'am. Oh, I can go, ma'am.
Okay,
Inshallah.
so there was pathology. Okay, so if you're ready, can I start the timer?
Yes, ma'am.
Okay, started the timer, and here is your question. Right, if you have read and understood and considering it surgical pathology station, kindly tell me what is your provisional diagnosis?
Ma'am, this could be a case of pleomorphic adenoma.
Okay. What are the features of pleomorphic adenoma?
Pleomorphic adenoma is basically a benign tumor of the parotid gland. Here, the patient will present with parotid swelling, and there is going to be the swelling will be firm in consistency, well demarcated, and will be mobile. And it won't involve the overlying structure or the overlying skin or the underlying structure, and usually facial nerve functions are intact.
Good. Okay. Can you tell me what you understand by the term pleomorphic? What does it mean to you?
Pleomorphic means that it is usually a biphasic or a combination of cells arising from both epithelial, myoepithelial, and mesenchymal in origin.
Okay, good. Can you please tell me how would you classify tumors of parotid region?
According to
Parotid
the
gland.
World Health Organization, the classification can be benign, malignant, and others. Benign tumors are such as pleomorphic adenoma, Warthin's tumor, oncocytoma. Malignants are mucoepidermoid carcinoma, acinic cell carcinoma, adenocarcinoma, adenoid cystic carcinoma, and others such as lymphoma.
Okay, good. Can you tell me what is the most common parotid region swelling, which is benign?
Pleomorphic adenoma.
Okay, good. Can you tell me what are the signs, clinical signs of malignancy that you should look out for?
Signs that show that there is malignant transformation is rapidity in increase of the size of the swelling, usually hard inconsistency, involvement of the underlying structures or the overlying skin, and usually the involvement of the facial nerve.
Good. Can you tell me or describe the pleomorphic adenoma from histological point of view?
Pleomorphic adenoma, and in the histology there is going to be the parotids, there's going to be there's going to be
Yes.
there's going to be lymphocytic infiltrations within the stroma, and there is the cells are going to be enlarged. Cytoplasm is to a nuclear ratio will be 1:1. There's going to be no invasion of the basement membrane, and there is usually anaplasia and also hyperchromatic nuclei and eccentric placement of the nucleoli.
Okay.
And dense chromatin nucleus.
All right. Can you please tell me what are the investigations that can be asked for in the patient with parotid region swelling?
Ultrasonography of the parotid region, fine needle aspiration cytology of the swelling, as well as a xylogram can be done. And if we suspect this is a malignancy, we can do CT scan of the head, neck, and the chest.
If it was
two-stage.
Okay, can you name one test which can differentiate between benign and malignant cells?
FNS, fine needle aspiration cytology.
Okay, good. Okay, can you tell me if you do histology or on the histology report, what are the features which will point towards malignant diagnosis?
Usually, if there is invasion, that means if there is malignant cell involvement of the basement membrane, and if there is then there is increased mitotic increase in the number of mitosis. If there is presence of giant cells, then as altered cytoplasm is to nuclear ratio is to 1, that is 1:1, and if there is a hyperchromatin dense hyperdense chromatin.
Okay.
Material.
And there will be loss of differentiation.
And loss of differentiation and
abnormal chromatin
yes,
pattern, etc. Okay. Can you tell me if there is possible during surgery to rule out if the lesion is malignant?
Yes, ma'am. We can do a frozen section.
Okay, good. Can you tell me how would you differentiate between a cytology and a histology?
So basically, cytology is the study of cells, whereas histology is the study of cells in context of a tissue, and that is the study of the study of the tissue as a tissue architecture as a whole. Cytology usually is done by getting samples through either fine needle aspiration cytology or through brushing, and histology is usually gained by a biopsy.
Good. Okay, if you find lymphocytes or Langerhans giant cells, so in the lesion, so what would you think?
Perhaps it's a granuloma.
Okay, good. And if upon doing FNSE, fine needle aspiration cytology, if you come across epithelioid cells and brown cytoplasm, then what would your interpretation be?
Malignant melanoma.
Okay. How would you describe high sensitivity test?
High sensitivity tests are those tests that are used to correctly identify the patients who have the disease. That means it is true positive tests.
Okay. How would you differentiate it from high specificity test?
High specificity are tests to identify those patients without the disease. That is, it is the true negative, with a negative test.
Okay. Can you please help me and read this image? What is
Yes,
this
ma'am.
arrow showing?
Ma'am, this is the CT scan of the head, which is showing a swelling in the parotid region, which is well
Head or face?
circumscribed and face, and it is having a cystic swelling and is unilateral and does not involve the surrounding structure and well encapsulated. So perhaps this could be a benign tumor of the parotid gland, but because of the cystic consistency, it could be Wathin's tumor.
Okay. Can you name few benign tumors of the parotid region?
Pleomorphic adenoma,
And
Wathin's tumor, oncocytoma, then blastocytoma. I forgot. Sorry,
okay.
ma'am.
And what about?
Myoepithelioma.
Can you name few malignant parotid region tumors?
Yes, ma'am. It could be mucoepidermoid carcinoma, adenoid cystic carcinoma, acinic cell carcinoma, and
Okay.
lymphoma.
Good. Can you please tell me if while performing fine needle aspiration, your assistant gets needle injury, what would you do?
So, ma'am, immediately we're going to encourage more bleeding, and we're going to wash the wound under running water and soap, and then we're going to contact with the occupation has health department team and involve them if they're not and gain their advice. If they're not there in the hospital, then we'll speak to the accident and emergency department who have a policy for needle stick injury, and then we'll counsel the patient and take samples from both the patient as well as the doctor for hepatitis B, hepatitis C, and HIV testing. And also after that, we are going to speak to the occupation health department or the microbiologist consultant and gain post-exposure prophylaxis advice.
Very good. Good. Thank you.
Thank you, ma'am.
Can't see the chat. Okay. All right. Thank you so much.
Thank you, ma'am.
Good. Excellent. Yeah. It was random. Okay. Now I have Dr. Sunday and I have Dr. Mohammed. So who wants to go first? I have to get some history taking out for Dr. Sunday as well. Okay. So yes, I have two stations. Who would want to go first, please? Uh, one is communication skill and one is history taking. So yes, Dr. Mohammed, your network
Okay,
works?
ma'am, I am ready.
Yes. Can anyone
Okay,
help Dr. Mohammed?
inshallah.
Dr. Ulfat, would you be able to help him?
Yes, ma'am. Sure, ma'am.
Thanks. Okay, this is communication skills. So just a second, let me share the screen. It's communication skills, okay?
Yes, ma'am.
Okay.
So if both of you are ready, can I start the timer? Yes, starting the timer, and
Okay.
here is the question.
Yes, ma'am.
Yes, if you have read and understood, kindly begin your station.
Okay. Hello, I am Mohammed Alayan, one of the surgical doctor registrar working for Mr. Man in X Hospital. I am calling to speak to Mr.
Yes.
David as
Mhm. Hello?
Hello?
Yes. Summarize your case,
Hello?
please. Yes, I'm doctor speaking. Please
Yes,
summarize your case.
we lost you. Please
Ma'am?
summarize your. Have we lost him?
Yes, ma'am. Ma'am, can you hear me?
It becomes like this with. Yes, I can. Yes,
Okay,
I can
thought.
hear you.
Hello?
Yes,
Ma'am, not there, ma'am.
I am here,
Yes, ma'am.
but he got disconnected.
Yes, ma'am.
I've stopped sharing and I've stopped his station. I don't know. Network is really bad these days.
I think when it comes to this particular station and
His
Dr.
network.
Muhammad work, yes, ma'am.
Yes, and beside, mostly all over the world, people are working remote. So workload has become more, from their homes.
Yes, ma'am.
I am sorry, ma'am.
Is it? Summarize your case, please.
Okay, start.
Summarize, yes.
Yes.
Why do you think it's urgent? Can you not wait for tomorrow? Why do you think patient is urgent? Yes? Got disconnected again. Got disconnected, right?
Yes, ma'am. He got disconnected, so I could not.
That's bad. Whole surgical department is with us. Of FMC. I don't know what FMC is. Yes, this is like really bad situation when someone in the middle gets disconnected. Now I don't know to move forward or to sit and wait. Maybe we can, while we are waiting for him, we can discuss all the possible questions. Why
Yes, ma'am.
anyone thinks this is an urgent case?
Ma'am, because, oh, can I go, ma'am?
Yes, sure. We're discussing. He
That's,
will
ma'am,
come, he'll join.
because,
Otherwise, I've stopped his time.
all right, ma'am. Ma'am, because the patient is, atrial duplex is saying that the patient has acute limb ischemia, so which cannot wait. Urgent intervention will be required, or else we might
Yes.
even lose the limb.
Very good. So do you think before transferring her?
A cardiologist?
Yes, please.
No, ma'am. Because we can do that even after we have transferred the patient to under the vascular consultant's referral. We
Yes.
can because the ECG changes that have come is because of the electrolyte imbalance of the patient.
Yes. Yes. So what do you think of her presumed diagnosis of diverticulitis?
So most probably this is not a case of mild diverticulitis. Rather, it could be a case of
Anyone?
mesenteric ischemia. Oh, sorry.
Yes. Yes. Yes.
The changes, the ECG changes is most likely that of AF, that atrial
What else?
fibrillation.
Yes.
The ECG change, yeah, is most likely that of AF, and then it's possible that she has formed emboli in the atrium and then thrown some to the limb and to the abdomen. So she may have ischemic bowel, ischemic colitis, or ischemic enteritis. Hello?
Possible cardiac infarction. Yes.
So she may have
Yes. Yes.
possible
Yes.
bowel ischemia from emboli.
We can hear you.
Emboli. Okay. So I'm thinking she probably has bowel infarction from
Yes.
the emboli that she may have been dislodged from the atrium.
Okay. In the view of that, what are the possible differential diagnoses that one can think of? All the
Hello? Hello?
Ma'am has got disconnected, doctor.
Okay.
So I think, yeah, ma'am's back again.
All right.
Sorry, I got disconnected. My own network. Went off.
Yeah, about that.
Okay, I was asking you, considering this scenario, what are the possible differential diagnoses that one can think of? All the possible in this patient?
Okay. Sorry.
Yes. Can anyone tell? The network is bad. Yes. Bad
Ma'am.
at my end as well.
Uh-oh.
So it could be appendicitis. It could
Yes,
even be
ma'am.
cholecystitis. Could even be
Yes, ma'am.
pancreatitis. Could even be mesenteric ischemia. Could be meniscus. Could be infective colitis. Could be inflammatory bowel syndrome, ectopic pregnancy, considering it a late. Would you want during the patient or after the patient? Anyone?
Sorry, ma'am. What's the question, ma'am?
Whoever has good network, they can. Yes,
Um,
network is very
ma'am,
bad.
ma'am, what is the question,
First,
ma'am?
abdominal before transferring patient or after the patient?
Abdominal ultrasound. We'll continue
When
to
would
do
you do
serial.
abdominal scan?
Ma'am, we can do that even after transferring the patient. But we'll continue to monitor examine the patient's serial abdominal examination continuously till the patient is transferred under the care.
Very good. Good. Okay, can you please tell me how would you make your diagnosis on the fact that this could be mesenteric ischemia?
Diagnosis, we can confirm it by doing a CT angiography or a duplex, if the patient's renal function is not favorable, then we can do a magnetic resonance angiography and to exclude if there is any mesenteric ischemia.
Okay, if there is a possibility of mesenteric embolus, so what other images would you ask for to rule that out? Arterial duplex,
CT
yes.
angiography and a CT angiography.
Arterial duplex.
Arterial
Yes.
duplex, yes, ma'am.
And arterial duplex as well. Okay.
Yes, ma'am.
What to give as an anticoagulant and how?
We'll give low molecular weight heparin and
yes, how much?
sorry. No, ma'am. We'll give unfractionated. In this case, we'll give unfractionated
Bolus.
heparin. We'll give a
Bolus.
bolus dose of unfractionated heparin in 5,000 international units, and
Yes.
then we will continue to give it at 15 units per kg per hour until our APTT is within 40 to 60 seconds.
Very good. Okay, how this patient should be transferred? What kind of ambulance should be asked for?
A blue lighted ambulance which has all the equipments for cardiopulmonary resuscitation or and oxygenation.
What should be the plan of management for this patient?
Management of the patient would follow correction of the electrolyte imbalance, correction of the anticoagulation of the patient, and
atrial fibrillation, management
and the
of
atrial fibrillation, correction of the atrial fibrillation. Yes, ma'am.
Yes. And then patient also has metabolic acidosis, so you'll also take care of that.
Yes, ma'am. So yes, ma'am, we'll give
intervention.
sodium bicarbonate. Yes, ma'am.
If there is possibility of acute lung injury, acute yes, and then embolectomy if
that will be, yes, ma'am. So if we are transferring the patient under vascular care, so after assessing the patient clinically and from the time of the emboli, and then we can, if it is within 4 to 6 hours, then we can go for primary embolectomy. And if that is more than 6 to 12 hours, we can go for a bypass. And if more than 12 to 24 hours, we'll go for amputation.
Yes, good. Dr. Mohammed, what would you tell the family of the patient? How would you approach the family of the patient? What would you tell them?
Okay, I will tell them. Yeah, I will tell them that the patient has developed acute reduction of circulation in her lower limb, which we need urgent intervention, and we are going to transfer for vascular consultation.
Okay, can you please tell me what is the likely cause of leg swelling in this patient? What might have happened to this lady?
Yeah, can be get acute limb ischemia.
Yes, why? How? What happened?
Emboli.
Yes. Because
Because
yes,
the,
atrial
And
fibrillation.
emboli.
Yeah.
of the embolism result from the atrial fibrillation.
Okay,
Yes.
good. Right. In what kind of ambulance would you transfer this patient, Dr. Mohammed? In what kind of ambulance are you going to transfer
ma'am?
this patient? What kind of ambulance are you going to ask for to transfer the patient? You're calling the vascular
Ambulance will
consultant, right?
equipment
Yes.
with
Mm-hmm.
monitoring
His network, you
and
know.
cardioversion and the CPR equipment.
Yes, yes.
Okay. Would you
Correct.
take anyone with you? Who would help you with the transfer of the patient? Would anyone accompany the patient? Yes. Got disconnected. I think we have discussed enough.
Yes, ma'am, he's back on.
Then he can just tell. Otherwise, I think I have discussed the station enough.
Okay.
So, Dr. Mohammed, network was bad.
Yeah.
I stopped the timer
I am sorry.
and that's okay. No, it's not your problem. I even got disconnected. It's overall. So
Yes,
maybe
ma'am.
we can try again this station sometimes.
Okay, ma'am. Okay.
Yeah, because today network is very bad. You know, my own network is disconnecting. It's really bad everywhere.
Okay, ma'am.
Yeah. So should we call it the end? Network is really disappointing. And Dr. Sunday
Yes, ma'am.
also wrote that his network is not favorable as well. So we can't really go ahead.
Yes, ma'am.
All right, everyone. Thank you. Yes. Yes.